on to apologies for absence. In terms of apologies for absence, we have Zoe Azanapur, we have Tichafar Thiri, and Diana Sweet. And moving very quickly. And Anita, although I mentioned her at the beginning, so Anita's obviously not here. So we'll move straight on to the patient's story, and I really want to welcome you here to talk it through. I know our patient isn't actually here, but I'll turn to you first, and would you like to start, please?
Thank you, Chair. So I'd like to introduce Dr. Kat Bond and Senior CNS Sam King here, who are going to take us through the patient's story. Frailty touches everybody's lives, and very large numbers of our patients, not just in A&E, but every part of our service will be on some form of a frailty pathway one way or another. But really today is an opportunity to showcase an individual patient story, but also the complexity of some of the work that Kat and Sam are dealing with. So I'll hand over without any other comments. Thank you.
Initially, just run through what our service is about, a bit about frailty. So the hallmark of an older person living with frailty is their lack of reserve. They don't have the inbuilt physiological response compared to that of a healthy young person. Therefore, how disease presents itself is different. And when patients living with frailty have a stressor event, they tend to present with a frailty syndrome. So let's start with how we identify frailty. We use the Clinical Frailty Score, or Rockwood score. This is an assessment based on what their functional baseline was 2 weeks ago, not how they present when they're acutely unwell. And this enables us to identify if a patient is living with mild, moderate or severe frailty, and ideally should be done within 30 minutes of arrival to hospital. The graph on page 4 of our presentation, which hopefully you all have, is a really good visual tool to demonstrate the impact that a simple life stressor has on a person living with frailty. The orange line depicts somebody living with moderate frailty who on the surface appears to be managing, but adding a life stressor, for example, an accident, an illness or bereavement, this results in a prolonged recovery period. They never return to that pre-functional baseline. These are the patients who we can have most influence over, but are also most at risk of deconditioning and prolonged inpatient admissions. And Mrs. A's story is a really good example of this. So to talk a bit about our service provision, within the information that we have shared with you, it demonstrates how much we have developed and moved the service forward. And I referenced the service overview graph comparing activity from 2018 to 2025. I think it's particularly pertinent to reference the fact that we discharge over 50% of our patients who have had a comprehensive geriatric assessment. And these are the patients that are living with moderate frailty, those high-risk patients that I've mentioned. And it therefore emphasises the need for our intervention, not only to improve patient outcomes, but also the cost savings that are associated with, in terms of bed days. So what is next for our service? The ICB has set down 7 interventions to support in reducing unplanned admissions in the over 65s by 25%. For us, this means early admission avoidance review in ED, intercepting those patients as they arrive in the department, seeing if we can turn them around at that point, engaging them on a pathway via the care coordinator. Alternatively, if we're not able to turn them around at that point, completing a CGA and signposting them onto a suitable pathway, be that hospital at home, and bringing them back to our hot clinic, but facilitating that discharge back to normal residents. Equally, we're realistic that we can't discharge all patients. And for those that do need that short admission, we aim to transfer them to our frailty short stay ward, Ashwell ward, to continue that continuity of care and aim to discharge them within 48 hours. So we're in the process of recruiting a CNS who will be based within the ambulance bay to support in identifying those patients at the beginning of their hospital journey. So let's talk about patient A, our patient story. Mrs. A is an 86-year-old lady. She was found on the floor by carers following an unwitnessed fall. So there's our frailty syndrome. Following an assessment by the ambulance crew, she was conveyed due to hip and pelvic pain. She had a diagnosis of Lewy body dementia and a clinical frailty score of 6. She had not previously been seen by our team and she'd had no recent admissions. So She was identified by our frailty coordinator as suitable for a comprehensive geriatric assessment, and this was completed by one of our frailty CNSs and consultant geriatricians. She had no factors identified, but her routine blood tests identified that she was anemic, but asymptomatic, and therefore a decision was made in conjunction with her next of kin and LPA to refer her to hospital at home for further monitoring. The patient was accepted by hospital at home and discharged with safety netting advice. The hospital at home team reviewed this lady 48 hours later, as planned, and repeated her bloods. Her haemoglobin remained low, so they reviewed her again a further 48 hours later, and her bloods continued to show a downward trajectory, and therefore hospital at home contacted our frailty hot phone and spoke with one of our consultant geriatricians regarding the onward management. A plan was made for Mrs. A to attend our frailty hot clinic the next day for a blood transfusion. On arrival at the hot clinic, Mrs. A and her daughter were met by one of our CNSs and talked through the events that would follow as part of Mrs. A's assessment and treatment. She had repeat blood tests and was given a 2-unit transfusion. Following a discussion between Mrs. A's next of kin and our consultant, it was decided that Mrs. A was not for any invasive investigations for her anemia, but a referral was made to the haematology team to review based on the clinical findings. And Mrs. A was discharged home accompanied by her daughter. So I'm going to talk about her advanced care planning because Mrs. A's next of kin, who I spoke to, made specific reference to this conversation and the positive impact that it had on her. Resuscitation and advanced care planning were not something that Mrs. A's children had discussed, and initially when it was broached in ED, it was not something that she felt comfortable having a conversation about. The ability to have that time to go away and think about what this means and have conversations with other family members allowed time to process the information that had been given and talk through and plan decisions. So on returning to hot clinic, these discussions were revisited, and it enabled Mrs. A's next of kin to think about her mother's wishes, plan for her changing and increasing care needs. Mrs. A's daughter expressed that she now feels ready and prepared for what happens next. She felt really supported in that decision making by the team, and the respect form was completed in clinic, detailing Mrs. A's wishes, focusing on care outside of the hospital, and she's not for resuscitation. So relative feedback from Mrs. A's daughter from her perspective, she highlighted the following points. Continuity of care. The next of kin recognised that her mother would not remember individual people due to her dementia, but she remembered how they made her feel. She really perked up when the team engaged with her mum. The attention to detail. Mrs. A had a small stuffed animal cat with her, which had a name and was a really integral part of keeping her calm and engaged in the throughout her hospital visits and the various assessments. And this was remembered by each member of the team. Delirium. So mum has always been more delirious in hospital, but this was minimised because of the attention to detail, because of the continuity of the care, because of the time taken to explain things clearly. Everyone was sensitive to my mum's needs. I was helped with every aspect of her care. Nothing was too much trouble. I was anxious about navigating her infusions, taking mum to the toilet, but the team stepped in and supported her without hesitation. And I was looked after too. I wasn't on my own. So to summarise her experience outcomes in Mrs. A's daughter's words, there are so many positives to take away from our experience. The respect conversation and the discussions, I feel prepared. Keeping Mrs. A out of hospital minimised her episodes of delirium. Continuity of care from start to finish. It was the same consultant that saw this patient. It was the same CNSs. And that was a real point that she emphasised. The team were amazing. There was nothing that I would have changed about our experience. So what would the alternative pathway look like if we hadn't intercepted this lady at the point of arrival? So she would have been reviewed by the ED team, referred to the medical team for further management of her low haemoglobin. She would have experienced multiple bed moves as a result of her admission, and it was already identified that this lady was very high risk of delirium. The outcome would have likely resulted in an extended length of stay, causing a shift in her functional baseline, thinking back to that orange graph and that big dip that we see in this patient group, resulting in increased care needs on discharge. And the family expressed that their experience would have been very different had the patient needed to stay in hospital. So what's our learning from this? So Mrs. A's story highlights the excellent and vital work that our service does on a daily basis. That collaborative working with community services and that seamless transfer between primary and secondary care avoided an admission and avoided a prolonged hospital stay. For those patients who do need admission, the aim is to minimise their length of stay where possible and to minimise that risk of that deconditioning and delirium. Hence the need for adhering to our Ashbourne Ward criteria to maintain that flow through our short stay ward. It supports the 7 interventions set down by the ICB in reducing unplanned admissions in our over 65 age group, and the positive impact that this experience had, not just for the patient, but also for the relative. And now I welcome any questions.
Well, thank you very much. That's a really interesting and excellent story. I think as well it emphasises so much how important it is when we look at the care of people who are frail and how the way we care actually really influences the outcome for them. So really, really important. I have one question for you and then I'm going to open it up to the rest of the room. So my question is that we are heading into the winter. I know it's only the beginning of September, but we do know we're doing our winter planning. And this is such an important area for us in terms of our planning. So what do you think we need to be doing now to ensure that we can handle this as effectively as we can to get the best outcome for our patients?
I think one of the key interventions we already have planned is to try and meet people at the front door, to be as early in the journey as possible. And we know that for some frail older people, they arrive in an ambulance, but actually there isn't anything different today than any other day. It's just something has gone wrong, which has resulted in an ambulance being called. And if we can intercept those people right at the beginning of their journey with some assessment and some safety netting, that's a big win. I think the other key thing is that in order for us to do an adequate assessment, we need space. And that when winter hits and ED is under a lot of pressure, that's very difficult. As much as possible, we'll use our hot clinic to bring people back for the majority of their assessment if there isn't space and time to do it on the day. But just having some space ring-fenced in ED to be able to assess patients is really, really important.
Thank you. So David?
Thank you. My name's David. I'm a non-executive, so I can't really think of many more important topics. You know, the prevalence is huge. The prevalence is increasing. It's undoubtedly a burden for the person, the patient themselves. And actually, we've got a much bigger problem. It's going to be a difficulty, a burden for society because we haven't got enough people in work to support older people in the years to come. And I've seen, my mother's 94 tomorrow, and I've seen her become frail over 24 years, 25 years. And I can bring in the resources. I know the local primary care centres, and I found it difficult to change things. So my question is an extension of your question, really, is because we can't do this alone. So how we as a trust, do we as a trust have a real discernible working plan to work with primary community care to actually change this?
So as the case demonstrated, we're already linked in very closely with HCT, who are our community partner, and we need that co-working so that they support us to get patients out of hospital and we support them when they're supporting patients in the community who need something extra, whether that's a short admission or a hot clinic assessment. We're engaging with the local neighbourhood teams via the neighbourhood MDTs. At the minute, that's only taking in a very small number of patients, but as time goes on, we'll have assessed with them the most at risk, most frail patients to try and put in place support for now and a plan for an emergency. And the hope is that we can link those people more quickly with hospital home when things are deteriorating in the community to try and avoid them going sort of deeper into a crisis. But it is a huge task, and whatever we do, there's always more that we could do.
Yeah, and what I hear you say is great. I fear it's the tip of the iceberg.
Yes, I think the bit that we could do better is the linking with palliative care. And if we had the same kind of relationship with the palliative care teams in the community that we have with HCT, there's probably something extra that we could do with that.
Hi, Kevin Howell, Director of State Facilities, and apologies if you've gone through this, but the success of this is all based on the fact that the flow through Ashwell and the 48 hours we're talking about. I've noticed that the delirium, mum always gets delirious in a hospital, so getting out there. And it's very easy for us to say primary care problem, blockages at that end. I suppose for me, I'm saying, what's within our gift to speed things along and assist internally before we say there's nowhere for it to go outside? I mean, things like test results, things like that. Is there anything we can do internally to maintain the flow through Ashwell, which I think is, what I heard from you, is absolutely immense, because otherwise you end up with the frailty ward rather than a frailty unit.
I would say we should be thinking about discharging our patients at the point of arrival. So if we're waiting until they're medically optimised to think about discharge planning, we miss the boat, because they're complicated patients, they're not straightforward. Any of us in the room, we come to hospital, we're better, we go home. But with our patients that we're talking about, with that dip in that baseline, we need to be thinking about what are we going to need to get them out at the point when, and that's very much what our assessment encompasses. But obviously we see a snapshot of those patients, so we need to change our thinking across the board about when we start thinking about getting people out, and that should be part of our plan at the beginning.
So, from an Irish background, they used to say it's the Irish welcome, and it's the first thing that an Irishman asks is, when are you going home?
And I think the other thing that we could do to maintain flow on Ashwell is to flow people out of Ashwell if we recognise that they're actually going to be there for more than 48 hours. So to make sure that we use the resource as effectively as possible. If we identify people as longer stay, we move them through to a tower bed so that we can then use that bed to turn over another couple of patients.
There's lots of enthusiasm in the room, so I'm going to Adam, then Richard, and then Kevin, and then Stuart.
Firstly, thank you for bringing that to life so beautifully in the way you presented on this patient's story. You spoke about 50% of presentations being able to be turned around without admission. So my first question would be, is that the right level, or do you think there is scope for increase? Looking at the data, I was looking on Model Hospital very recently, and we've got about the shortest length of stay in the country for our frailty patients. So we are turning people around relatively quickly, not to say there's not more we can do. And I know we did some work with the hospice, I think Garden House particularly, and we've already mentioned Hospital at Home who we're working with. Is there any more in those areas you think could help with if 50% could be increased, but also recognising the 50% we do admit might be perfectly appropriate to admit because this is the right place for them. So just a sense of the possibility if where the balance is now compared to that, because it's been touched on, we know that the exponential growth we're going to see in this part of our population means we are talking about frailty more than anything else across the system, and we will continue to do so. So that the prize is massive for our patients, but also operationally in terms of running the system.
I think from a point of view of sort of medical and nursing issues that result in people staying in hospital, there's probably not a great percentage extra that we could be turning around. Sometimes Hospital at Home are at capacity and they can't take our patient for up to 24 hours, but that's not a massive problem. I think that the percentage that we could have an impact on the people who are medically fit for discharge but need something else. They need something from social services, they need a short stay, discharge from cess bed, or they need a permanent placement. That's probably where we could have the biggest win.
And how about the hospice angle? Is there the more they could be doing? I know they're keen to do more, or for the particular patient group that they're taking, is that kind of at the right level in terms of support they can offer?
I think it's probably about right. I guess we have a very good service from Garden House, but it's not matched in the south of the patch by Isabel. So I guess there is a disparity in terms of what patients can access.
Okay, thank you.
Richard?
Yeah, it may slightly overlap with Adam's question. My name is Richard, I'm in that as well. So I was wondering, this is the ideal path, and I can clearly see why this works really well. And do we know how many people do not follow the ideal path still? And so is there an opportunity for us, because this is captured early on at the front door, how many people are not captured properly at that point in time? And secondly, can we do more to prevent them entering the hospital in the first place?
So I think what we're finding with the improvement in community services, actually the appropriateness of the patients that are presenting, they've been engaged in community services prior to presentation, and they've had hospital at home, they've had community therapy, they've been involved with the hospice, and actually they are unwell and they do need to be here. And that obviously has an impact on the number of discharges that we're able to make, because actually they're sick and they need to be here. And I think we also have to be realistic that we're still a hospital and people still need to be here. In terms of, can you just refresh your question, please?
So how many people do not follow the ideal path?
So out of hours is the tricky bit for us.
Right.
So obviously these patients that are presenting to us, they are low priority in terms of the stack for conveyance. So actually when they are presenting, they're presenting later in the day and then into the evening. Or they're presenting, they get up at 4 o'clock in the morning to go for a wee and they fall over. So it's that out of hours element, and we're not a 24-hour service. And also we have a limited resource, we can't capture everybody. The ideal money no object, we would be here 24/7. And
the community services would be open 24/7.
Yeah. And we would capture everybody, but it's that out of hours element that we're not able to capture, and they're the patients that fall within that, and ultimately are probably the ones that end up with a prolonged stay.
Is there a way to measure that now? Because in the end, that might provide the case for 724 or not.
We can measure it. At the minute, our data isn't great because of restrictions of Nerve Centre, but when we have the new IT system, we should be able to be much more clear about that.
Okay.
So thank you, Sam. I mean, really excellent presentation, and like Adam said, you really brought something to life for us there, and it's really quite powerful and impactful, and probably resonates with so many of us who have family or friends going through sort of similar challenges around the country. And it's really exciting that you're looking into the neighbourhood health team and what that kind of looks like, because that's a really exciting piece, and that kind of radical shift into prevention. It sounds really good. I'm really taken with the similar services, because I think the Frailty Service and HCT Community Services have now for a couple of years really felt like you've collaborated, worked really closely together, and kind of redesigned services and pathways with really the patient at the front of it. And that's why it really feels so impactful for me. I'm just interested in learning and insights that you might have that other services, both internally and externally, might benefit from, because what you say and articulate as quite natural is actually for some different areas still quite a challenging place to reach.
That's a difficult question.
Yeah.
I think
I didn't think to be.
part of it is relationship building. So it's generally the same practitioners within HCT who are working in hospital at home, working in our community frailty clinic, and we're liaising with via MDTs that run for those services. So I think it's about building trust on both sides.
And I think also having that face-to-face contact. We've gone to hospital at home and we've done teaching and education, and actually sitting around a table and having conversations and talking about patient scenarios and just meeting face-to-face. We're really good at, teams and things are brilliant. We were talking about this, that, it gives us the opportunity to talk to people all over the country, but actually still having that face-to-face contact with people. Oh, I met you, and actually now I feel happy to pick up the phone and have a conversation and ask those questions that, ordinarily might be a bit like, oh, is that, is that a bit of a risky patient?
breaking down some of those barriers, that the frailty hotline is held by a consultant, but any practitioner from the community can phone us, you know, and some of that face-to-face contact helps with that.
That's great. Well, thank you.
Just a couple of quick points from me. First of all, I think we've got exceptional clinicians in frailty. All credit to yourself for not just this patient, but the bulk of the patients that we manage. I think for a patient with a long-standing dementia, it's very to be commended the fact that accessibility around diagnostics and diagnosis is a key part of that pathway. They're not just labelled as a dementia patient. I just wanted to highlight that because I think that's really important for many folk in the room and outside. The second point I wanted to make, and Sam, this is a commitment I've made to you and the team, is that we need to look at the expansion of frailty nurses around through influence and how do we work up to the optimum of where they could be and what does that look like in terms of advanced practice, so I haven't forgotten. And another wee commitment from myself and Kevin is to find that space where our frailty nurses can have really complex conversations with families, because right now you're kind of in an ad hoc environment, am I right, in trying to make phone calls, examine patients. And my final point, I will be quiet, is that this is the future, Chair, this is the future. And we'll sort of talk about lots of tech and everything else. It is about the people impact. And so I think this is all linked to the ambition around the service and how do we make sure we support yourself and Kat to go on.
And Lucy.
A point and a question from me, or a thank you actually, and a question. Firstly, thank you for everything that you do, and secondly, for the work that you're doing with the ED team to make our clinical decision unit into that proper assessment unit base, which hopefully will be better fit. I'm sure not perfect, but better fit going forward. My question is more about kind of in the way that society thinks about frailty, and even about what we call it, because I don't know, I see in my family, my mum's 80, you know, and she had a fall about a year ago. There's that kind of, in the early stages, it's quite difficult perhaps to get across to both individuals and their families that this is, you know, the beginning of a frailty journey. And even the word frailty kind of, you know, I'm not frail, what are you talking about? I go walking. How do we as a society, you know, because actually those of us that work in hospitals, you know, start to learn about deconditioning and all of that. It's counterintuitive to most of the population, isn't it? You go to hospital to get fixed and get better. Is most people's kind of starting understanding of it. What more do you think can happen? It's not really what we do, but that, you know, where does society put its efforts in kind of changing the way we understand getting older and that kind of natural process of becoming more frail? I mean, it's not a good word.
I think sometimes people can engage better if you talk about resilience going down rather than becoming more frail. It's the same thing, it's just the other way around. Yeah. And I think sometimes that's helpful because if on a public health scale, if we can talk to people about trying to maintain their resilience or increase their resilience, so frailty isn't always a one-way street, then where it can then engage people in ageing as well as they can by trying to maintain their resilience.
I think also it's about setting those realistic expectations. You know, you come into hospital and you've been here for 2 weeks. You're not going to go home and be well. It's going to probably take you as long as you've been unwell, if not longer, and you may not return to your pre-functional baseline. And I referenced the graph, and we reference that graph, we show people that graph, because actually when you see it on paper, you can then understand. People don't like being called frail. We tell people that you come into our frailty hot clinic, I'm not frail, I'm fine. But actually, like I said, when you explain it, oh, okay, yeah, that's okay. And I think it's about explaining it and giving the rationale, and maybe just changing your language slightly to make people engage in what we're doing.
Thank you.
What you're doing sounds fantastic, and it's great to hear about all these relationships. So I'm Janet, non-executive director. but some of it's built on kind of individuals in posts and particular relationships people have. If we're thinking about the workforce strategy that needs to be in place for the future vision and the move towards neighbourhoods, do you have any thoughts around particular roles where you think if only we could take a little bit of that position and a little bit of that one and mix it together into a slightly different sort of role? Do you sort of get that sense, or does it all the roles kind of working well from each minute?
I think there's definitely more we could do with InReach into the Trust, because as we said early on, the frail old people are not just seen by the fertility service, they're seen by most services in hospital. And I think at the moment we don't have a lot of clinical input in the dementia support team, and if we were able to bring that together with the frailty team, definitely in terms of InReach, I think that will be something that will be very beneficial.
And what about back out into the community, where you've got other clubs you're imagining you're delivering much closer to where people are living?
I think that's through engaging with the neighbourhood team. So we already have better links than we did, but we need a better system, a smarter system, because at the minute it relies on us thinking, okay, that patient lives there, and so that's their GP, so that's the neighbourhood team that they belong to, and making that effort to then contact and ask for the patient to be reviewed or pass some information on. So I think there's probably something we could do with IT to make that less clunky and more accessible for everyone.
Are there any more questions from any other members of the board? No? It's been absolutely fascinating, really helpful. I've written down some words that I want to take away around out-of-hours planning. I think there's lots of things for us to think about that. And things to think about in relation to hospital, the way we work with hospitals, comparative care, about our workforce planning. And I also wrote ambition, because I think this is an area in which we do need to show that ambition, because it's an area that's it's growing, isn't it, all of the time. So really helpful, huge areas for us to think about. And thank you very much. It's been really clear and really helpful. So thank you both. Thank you very much. Yes, very much.
Thank you.
Do people want to shuffle around? Because it is quite.
They like the pack.
They like the impact. Excellent. All right. So if we just move on through the meeting. So have we got any comments on the minutes of the previous meeting? No. Moving on to the action log, please, Stuart.
Okay, yes. So my name is Stuart Alton, I'm the head of corporate governance. So for the first action, the renal services action, just to highlight to the board that the action log will be going to Trust Management Group tomorrow for review and then in train for being published on the website as stated. For the three other actions, the updates provide updates and they're on track. So I don't know if there's any questions from any of the actions.
Does anybody have any questions on the actions? No? Okay. We can note that item. Do we have any questions from members of the public?
No questions from the public.
Thank you. So moving now on to the Chair's report. So the first thing I wanted to mention is the fact that we do have 4 general management trainees, but there are 3. It says 4 on my side. I think we've got one missing, haven't we? But it's to welcome you. You're here to observe the meeting, and you are really welcome, and we wish you all the best in your careers. I should name you as Emma Evangelina Miles, you see, so I think I've virtually got that right. And I also wanted to welcome Ivana and Neil, so apologies for not doing that at the beginning. And who of course are from Health Watch. There are a couple of items on the agenda that we just need to ratify. And this is, we need to ratify the Baxter patient-specific SLA. It was approved as a chair's action, and it was reviewed at the May FPPC, and they all agreed it at that meeting to be signed off. Is everybody happy to ratify that particular SLA? Yeah. And also for ratification, we have the Cath Lab refurbishment. It was also approved as a chair's action, and it went to the July FPPC meeting. Is everybody happy for us to ratify that as well? Thank you. And the other thing I need to mention, Anita is very keen for me to raise the Leadership Live meeting that's coming up on the 14th of October, and it would be really good if as many NEDs as possible as well could attend that event. So again, just one to highlight to everybody. And I think that is the end of my list of things that Anita's asked me to mention, so I can move over to you now, please.
Thank you very much, Chair. I'm Adam Saul-Jones, the Chief Executive of the Trust. There's quite a bit in the report, and I want to dwell on a few because they're a number of quite important issues. The first thing is just to really mention the 10-year plan. It feels a long time ago that it was launched, but actually it's since our last board meeting, and it is a fundamental document shaping the future of the NHS and care more broadly. People will be aware of the three kind of headline shifts, which are about moving more services from hospital to community, a bit like we've heard with the patient story, to keep people away from hospital unless they need the services. A shift from analogue to digital, and a desire to have more and more access to healthcare through a digital opportunity. And the idea of really shifting from being a service that just treats sickness, but actually does more in the areas of prevention, either prevention of people moving further into healthcare, but particularly working with our partners in other bits of the care system where we can really prevent people coming into ill health. So lots going on there, and we will hear more and more about it. The plan is aspirational and is probably still a bit light on the delivery chapter, as it were, of the plan, and that's being worked through actively by the national teams and the Department of Health and Social Care, together with lots of input from the service to really shape what that looks like. I mentioned in the last meeting that the proposal was there that we will be changing the ICB formations, and that has now been formally agreed, and the new chairs have been announced of those clusters. We are waiting for the announcement of the new chief executives, and our cluster is as previously predicted, which is Cambridgeshire and Peterborough, Bedford, Lutonshire, Milton Keynes, BLNK, and the Hertfordshire bit of Herts and West Essex. And we will be called Central East ICB, which saves us being BLNK-CPH, which would have been a mouthful. So whether or not you like Central East, it's better than the alternative. But more importantly, I think what will happen now, the clusters are intended to work in effect for the rest of this year, but the legislation and other things that need to come in place are likely to be from the 1st of April that we will formally move into new ICBs. But there is still lots of work in the background to understand what the role of regions are, and there's just been a new regional blueprint produced in the last day. I'm sure it was produced before, but it was published yesterday. And I think people are then just getting their heads around what regions do in this new role, what ICBs do, and what do, importantly for us, providers leaving place do in a new world. So lots of excitement there, but also lots of work to be done, which I guess I put on record thanks to those involved in the Trust who are doing this on top of busy day jobs and really making some great progress. The next section I've highlighted is national recognition, because we're probably not good enough at blowing our own trumpet when the time is right. But we've been shortlisted in the Health Service General Trust of the Year award this year. There will be the next stage of that process takes place at the beginning of October, and then the awards ceremony will be taking place in November. But to be amongst a very small group of trusts who have been shortlisted as finalists is real testament to what staff across the organisation have been doing. And I won't mention them individually, but I have included in the report a number of individuals and teams that have also been shortlisted for national awards. There will be the risk of putting a list like this is you always miss some off, and I'm sure I have. But these ones, particularly Nursing Times and the Health Service Journal, are kind of very well respected national awards, and it's great to be in that mix and getting some focus. So congratulations to everybody who has been recognised in that way. We had a board-to-board meeting very recently with our partners at HCT, the Community Trust, and they've all already been referenced. And I think as more and more we need to be working in a more integrated way that many of our staff, as we've heard, do. I think it's just important that we keep that happening. We've agreed the next meeting will be in February, but we have some exciting activities taking place. Actually linked with Frailty, Kevin is going to be leading a 3P event, which is part of our Eastern North Heart production system, with HCT and other partners in November to really reimagine what front of hospital care could be like, so that in answer to kind of Richard's question, we can get closer to every single person going through the right pathway rather than any variability. So lots of enthusiasm for that work.
We've already started sharing diseases with each other.
Yes. There's a rumour that some of the recent ill health came from that event, but it's a rumour and not substantiated by any evidence yet. A bit of work on the states here to mention. The people will be aware of the new development taking place at the front of the hospital. There is some slides attached, which if people have got any questions we can come back to. But really the importance of that, and the importance for our staff and the public in understanding, is that this is being built and owned by a commercial partner. We will have access to use 2 floors for office accommodation at a very low cost, and that partner will be running the ground floor. That ground floor will provide more commercial opportunities for the benefit of our patients and staff, so more shops to be using. And that commercial model funds the build, and that's the way we've been able to do it. So I know we've continued to get the message right that in a time when we know the finances are challenged, that people say, well, why aren't you spending that on the deficit? Well, we can't do that because it's a different pot of money, and also other capital requirements where people would like to see more car parking or other things. We have to be really clear, this is a commercially viable model because of the revenue that comes through those shops. And that's the reason this is an add-on rather than replacing anything else. But there will be some disruption. People will have seen the hoardings at the front of the hospital, but we will maintain access throughout. And that will be an exciting project once it comes out of the ground. Financial update, Martin will talk more about the underlying position, but I just wanted to flag that we trialled a new approach a couple of weeks ago where we did a week-long event on variable pay. So all of that pay cost, it isn't about substantive members of staff, bank and agency, outsourcing, waiting list initiatives. And really bringing staff across the organisation to understand what opportunities might be there to reduce that, as well as improving across a number of other domains of quality, service provision, etc. There was a real buzz around with some significant opportunities coming out of that week. Some were implemented immediately and others are now being worked up. But I think this really highlighted an approach that we want to take forward in terms of our annual process of bringing people together, bringing frontline staff into the debate to look for opportunities. People will be aware maybe from some of the media, there's been some concern this year that across the country, midwifery students, but also nursing students, are coming out of graduating and not being able to get jobs. And whilst when we host students, it is only a placement for their study, we do pride ourselves on the fact that we try and offer as many opportunities for those people coming into employment. One of the areas that the government have allowed this year that we've exploited a bit is if we have vacancy in some maternity support worker posts, we can convert those into new midwife posts, and so we've been able to offer those out. And I think I'm correct in saying, I certainly was at the latest update, that any nursing student or midwife student coming through has been offered an interview with us, and we believe if they choose to come here, we will be able to secure employment. The positive is that part of the reason we don't have the opportunities is that our retention is improved, and we've recruited well in areas like maternity, and so there aren't the opportunities. So there's always a yin and a yang in some of that. But I think we've managed to get into a good position where there's been a national challenge on that. Again, I mentioned some things here where we've been celebrating individuals. We had our annual awards, which seems a lifetime ago, but again was since the last board, and a really fantastic evening of just celebrating what people have been doing, often in a very quiet way in the background, but most of these awards come from colleagues who have nominated colleagues for what they've seen and observed, particularly underpinned by our trust values. So that was a great event, and there are links. There's a link in the paper for anyone to look at. I won't draw on the other things that they're there to read. We are entering, as has already been highlighted, kind of winter early, and we've definitely seen over the last 2 or 3 weeks an intensity building around emergency presentations. We're seeing COVID not just in members of our board, but in the wider population. And whilst fortunately COVID is not the disease it was a few years ago when we were clearly in a different position, operationally, because of infection control requirements, it does create additional pressure. So we have to continue to monitor that. And at the end of the meeting, we'll come back to our winter plan there. But we've also seen the change in our doctors. Our resident doctors have gone through rotation, so we welcome those new doctors to the Eastern North Herts family. I just want to touch on 2 other things that have a bit more substance. One is the provider capability return, and we have attached to the paper here just the front page document of that return as part of the assessment that will be used by NHS England, but also I think going into Foundation Trust assessments, integrated health organisation assessments. The capability of leadership in the organisation will be reviewed. The starting position is that for us as a board to do a self-assessment against a range of domains. It's not just us saying, oh yes, so let's say yes for everything. We need to back it up with evidence, and that will then be challenged by the ICB region, etc. So we'll be going through that process, and the deadlines have been set up here. So the 22nd of October is when we will need to submit that work, and that will be pulled together. Sorry, Stuart.
So just highlighting, we need board's approval for the delegation of your sign-off.
Yes, I will come back to that. But thank you for the prompt. And the other thing to highlight is that linked to kind of assessment, people will have been aware, I'm sure, that yesterday the new segmentation of providers was published. Importantly, that comes with a very public-facing assessment that the public are able to look at and see how every organisation is rated across a range of quality, operational, financial metrics. It's driven by a desire to have more transparency and set out that through those segmentations, the system is able to provide more support to organisations who are performing worse. They have, you can argue, helpfully or unhelpfully, been set out in a league table, and people naturally want to jump to where are you in the ratings. And every quarter, I'm sure there'll be movement around with people moving up slightly or down slightly, and potentially moving between segments. The positive for us in what's been published is that we are in segment 2, which is the second of 5 segments that form this system. And actually, in terms of acute hospitals, we're the highest performing in the region. The only ones above us in the region are a Papworth as a specialist hospital and 2 community services further east. And I think that's real credit to the overall performance of our staff across the organisation. We have been rated 19th out of 134 acute and specialist hospitals. And actually, even more impressively, when you look at that list, certainly I think it's 8 of the top 9 are all specialist hospitals that don't have some of the complexities of ED and maternity and other challenges. So it's only a point in time, and we certainly don't want to rest on our laurels because the challenges increase and we need to make sure this is a motivation for even better. But I think it's it's wrong if we don't just kind of pass on our thanks to the organisation and the staff that deliver services on a day-to-day basis for hopefully moving us further towards our vision of being trusted by our community when they can see backed up by evidence of how we compare generally. So I will stop at that point and ask for the agreement that Stuart has highlighted to allow delegation to the group that have been set out here in terms of some chairs of committees. And actually I did suggest in a tweak to this that we also add the chair of the Quality and Safety Committee into that group as well, so that we've got coverage of all the domains around capability. So I'll stop at that point.
So to begin with, let's clear that one off first. So can we have approval, please, that the completion of the document will be by Adam, but we have oversight of it through the chairs through the chair herself and the chair of Audit Committee, FPPC, and Quality and Safety. Is everybody happy to approve that? Thank you very much. So we then go.
I think you'd like to include courtesy. Is there a reason not to include the chair of the People Committee?
If you wish to be included, I can't see that is a problem.
Yeah, we could definitely add.
Yeah. Okay. Yeah. So it'll be through all chairs. Okay. That's excellent. So we have agreement on that. Then just to track back, are there any questions on what Adam has said in his Chief Exec's report? I did just want to echo our thanks to everybody in the Trust for all of the real hard work that's gone into our scoring and coming number 19, I think it was, is excellent. What makes me feel really comfortable about it, though, I think this is the right word, is I know how ambitious the Trust is. And I know where we believe we've got a lot of work that we want to do to try and improve things and make things better. So I think it's an absolute assurance that we're pleased with where we are, but equally we believe that there's an awful lot of work that we still need to do in the interest of all of the people who live and use our services and for our staff as well. So, Stuart.
So just to highlight for any members of the public or staff who want to join our AGM, that's on Monday starting at 5:30, and the log-on details are on the website.
Thank you very much, Stuart. Richard?
Yeah, I mean, it's a really good summary of what's going on, and of course, good reason to celebrate as well, Adam. It still highlights a concern to me at the same time in terms of, and we could maybe echo that on different points, but it's the management capacity, right? There's so much going on from national, regional, ICB, HCP, and our own challenges in the Trust perspective, that I'm asking the question, how are we going to address that, let's say, in the next couple of months? We talk about the BAF. I could have raised it at the BAF as well, but I thought this was maybe the right time to just raise it. And I think we need to really think about how we do it.
Yeah, so just, I haven't got a response that answers the question with complete satisfaction, because it worries me as well. I think there are some opportunities. So I referenced the variable pay work, and one of the teams really want to spend some dedicated time on that. And so putting the challenge in about, so what meetings do we stop? And we know we've spoken about that a number of times, and every time we talk about reducing meetings, we review them, we add a couple more in. And I think it's been really, really very challenging on that. I think we need to signal from the board. I remember Jill made this point in a board seminar a while ago. We've got to be clear on some of the things that we might want to do, but saying now we can't do it. We're pausing. So we are, people are doing that on a daily basis, but we need to probably give a bit more overarching steer. And in terms of potential resource, some of the changes taking place within the ICB and having the new structures, there may well be a time period between the new structures being appointed to and announced and people exiting from the building. And during that time, the ICB have already said, we will have people around who potentially could be doing meaningful work that they are not needing to do in the new ICB, but will be available. So only last week, the chief execs across the system with the chief executive of our ICB, we were talking about how do we really give people some meaningful work, which may lead to opportunities going forward, but also to support some of this particular bump in the activity that's going on.
Just linked to that, we have had some discussion about the remuneration committee. I never said that word properly. Looking at sort of succession planning and thinking about that opportunity for people, sort of in terms of strengthening leadership, and that was something we had discussed as well, which I believe we will be doing later on this year. So that should also.
Okay. I think on my list, is there some you need to raise in terms of entrance care?
I was just going to have a quick review on the report that's in here. So luckily Adam has come in and explained what is a complex partnership, and I think the questions that have arisen from presentation that was sent out are surrounding that. And I just wanted to sort of tie this all up. If it was a timely thing to do, and a helpful thing to do at this moment, just to summarise what the original objectives were, where we are, and the timescales on it. And again, identify that we're in partnership with Novinity, who are the company of there. Compass are the company who are going to run the retail unit, and through their supply chain, they're going to pay through to Novinity, which is how the flow goes. That's for units 1 and 2, which is at the front of the hospital. And if you have a look at there is a video that's been uploaded now. That's very easy to identify where you are once you get an idea of exactly where it sits in the front. It does become clear. The partnership and the supply chain is Co-op, Costa, Stock Shop, and Peabody's, and they all have a guaranteed maximum rent that's sitting in there, which denotes that we have no financial input into this. On top of which we have a profit share, as you would do with any commercial aspect like this, and that's based on whatever the profit margins are that comes in. We get something that is clicked in out on a year-by-year basis on the income that those people say. I'd like to say that the benefit to the patients and visitors and staff is here without burdening our limited allowances and fundings. And we wouldn't have had this if we didn't have the retail unit. And I think that needs to be understood by people, that if the retail units weren't there, this money wouldn't have existed anyway. So we're utilising that. And one of the big things about this is we are going to get a civic entrance to the hospital for me. Sorry, I know there's a number of things, 24-hour feeding and everything else is in there, and they're all on that. But the civic entrance, since I've been here 5 years, I've always wanted to have a civic entrance. When you come here, you go, oh, that's the entrance to the hospital. I think we will get that. The details are all there, and it also has the timetable which are on there, which will be very strictly adhered to, I can assure you. And I'm happy to take any questions.
I've got one. Kevin, as you know, I'm really keen that we use the site as much as possible for health promotion. That's why we've gone to be a smoke-free site. We've already got really good cycle facilities and showers that are just off the plaza, which is great. The thing I want to do next is a public gym, an outdoor gym, because we're doing the refurbishment of the plaza. Would you be happy to look to see whether there are sources of funding that we could use in order to use that space and make it something that really works well to promote public health?
I'm absolutely happy to look at any options. We've got to remember we've done a substantive consultation of 6 to 12 months that included internal groups and external groups, exactly what was wanted. And a number of months back, we opened up a questionnaire to everyone to put in their information. 147 people responded with what they wanted. And a lot of it was around space where they can relax and a quiet area. Out of the 141 person put forward for the gymnasium, the external gymnasium, absolutely happy to do it. There are some, we did discuss this, the problem is we're not sure how many people would be happy to do their running or their walking directly outside the front of a hospital, but it's there. The other side of it is it's managing that sort of thing. These uses, anyone under 1.4 metres can't use these facilities, and the problem with that is we have a number of kids around, and how would I monitor, manage, how would the trust ensure safety? When it rains, you have to cover them. It's quite an extensive maintenance regime on these sort of things. You did give me the heads up on this, and I looked into injuries on this. Unfortunately, the only place that's got it is China. Last year there was 386,000 injuries on external exercise units in one of the main units. That's the only information I've got. I haven't got it in England, but I have concerns about the safety, the maintenance, the ongoing risk to the trust, and also it's not what was asked for in the consultation, but absolutely we can look at anything.
Just an opportunity I see to promote the charity. The charity has, our hospital charity has to complete its present projects that it has underway, but then there will be, but then the charity is always willing to consider, you know, health opportunities, particularly around patients, public, and of course staff. So I can't imagine it wouldn't encourage thoughts along those lines.
Can I also say that the charity have been at the centre of all this. So there are there's exclusivity issues, as you would do on a commercial issue. The only one that's definitely out of all of that is the charity. The charity is completely out of all the exclusivity clauses, the people that they bring in and their presentation in the front of the hospital, so they are in there, but absolutely.
I wanted to bring it to the board publicly.
I think it sounds like there are some opportunities for using the charity going forward. On my list it says for approval. Is there something we need to approve?
No, it's for noting.
Nice one.
My apologies.
I didn't think it was.
Sorry.
Anyway, okay. I think if there are no more questions on that, then I think we can move on to Health Watch, please. I think Neil, you're starting, are you?
Yes, that's okay.
Yeah, that'd be lovely.
So, thank you very much for inviting us to come and talk to you today. I'm Neil Tester, I'm the Chair of Health Watch Hertfordshire. Most of what you're going to hear is going to come from Ivana Chalmers, our Chief Executive, but I just wanted to set the context in terms of the quite substantial, but as yet quite nebulous changes that are going to hit Health Watch, but also going to mean some additional responsibilities for the trust in due course. I thought it would be really useful to discuss that. Great chance to talk to the full board because Teresa came and had a great, very frank and constructive chat with our boards just over a year ago. We have lots of contact at exec level and non-exec level, but this is the first time, certainly in any of our living memory, that we've come to your board, so really pleased to be able to do that. I'm conscious that due to local Health Watch and Health Watch nationally never having had much of a marketing budget, there are still quite a lot of people who've been knocking around the system for quite a long while who have a very vague idea of what Health Watch is for. So Ivana will say a bit more in her presentation shortly, but broadly there are four key themes that we brigade our work under. We're part of the national network of Health Watch. We're over 150, which must be commissioned by law by top tier local authorities because we've always covered both health and social care. And a soon to be abolished national arm's length body, Health Watch England, which supports and leads that network but doesn't have any performance management or funding levers over the network. I speak as somebody who used to work for Health Watch England years back. I bear the scars of trying to manage that. The four kind of key things that we're responsible for doing is firstly providing information and signposting to people about services, and that tends to be when people have tried every other avenue and have repeatedly hit the buffers and don't know where else to turn, and they come to us. So typically, that's an hour's conversation to help work out what someone can do, but also a really rich source of intelligence for us that we use in the sort of holding to account conversations that we have with organisations across the system, which we see as a really important part of our contribution to quality improvement. We undertake a significant programme of research and engagement, and over the last few years we've really tried to make sure that has a strong focus on enabling the voices of people who are least often heard to be heard within the system. And then very practically, we champion people's involvement in decision making. It's never in our ambition to do all of it. A large part of what HealthWatch is about is to help the system understand how to do that well, and how to facilitate that sort of co-production approach. So the 10-year plan envisages some quite substantial changes. As I said, the Health England organisation will cease to exist when the legislation is passed, and those responsibilities will pass to the new Patient Experience Directorate in the Department of Health and Social Care. The intention is to transfer the health-related functions of Local Health Watch to integrated care boards and to providers. Quite how that's envisaged to work, we're yet to see. And the social care responsibilities will pass to local authorities. The plan also sets out an increased expectation that providers will actively seek and use feedback. I think there are questions there about how we collectively make sure that doesn't become mechanistic and gives the rich contextual information that organisations really need to be able to do something with the feedback. That I think links to the ambitions in the plan about health inequalities and underserved communities, and a renewed and more central focus on tackling those issues. And so we think there are some issues that trust boards are really going to have to grapple with over the next 18 months, 2 years, 3 years, as this all gets designed and embedded, which is how to discharge the new responsibilities that you're going to be taking on as an individual organisation and as part of the wider system, but to do that in ways that build and maintain communities' trust, which I think has been a big part of the rationale for the contribution of HealthWatch. In the slide pack, I've given very edited highlights of what Dr. Penny Dash's review recommended in relation to HealthWatch. The government has accepted all of Dr. Dash's recommendations in full, which presents an interesting conundrum for anybody trying to. It's a bit like trying to interpret a religious text at the moment, because before the Dash review report was published, the media were briefed that we were going to be part of a bonfire of quangos. It was, made for some good weekend headlines. It was an atrocious way to treat thousands of staff and volunteers across the country who did not know that was coming and didn't deserve to be spoken to like that, which I think the department's acknowledged it dropped a brick in doing so. But the review recommendations are much more nuanced and much more interesting, but they mean that we have no real clue about what's going to happen as to whether you can read it one way as the function being moved into the system. You can read it another way as the function being taken over by the system. We've taken the view that while we need to be planning for all those eventualities, in the meantime, we just keep doing what we're doing. And the latest we've heard this week is that as there's no King's Speech planned for this calendar year and no date set for it yet in 2026, it's entirely possible that we could be doing this until well into 2027. But who knows? I'm not a betting man, fortunately, but if I were, I certainly would bet my house on it. So that was all I wanted to say, just by way of introduction, and I'll hand over to Ivana, who can give you a bit more about what all of that means in reality.
Thank you very much. Thank you. Lovely to be here, actually, and many of your faces are familiar from other meetings and spaces, so it's nice to see people in person, much like your colleague was saying this morning. Because you do know us quite well, because we have been welcomed, I'm not going to spend a great deal of time on technicalities. I'll just try and use a few minutes of your time, because we're a bit behind, to share a bit of the insights that we've gathered and a bit of our work program that's coming up. So hopefully that's okay. It's all in the slide pack, but for the purpose of this conversation, I'll just refer to a couple of things in there. You mentioned the 4 different functions that we do. One of them we call signposting or information and guidance, and it's really unsolicited public feedback we get oftentimes they will have engaged with trusts and organisations already. And we have a regular standing meeting with Teresa and her team, sharing some specific case studies and navigating what we should feed back to public who might come to us, and also what might be done in terms of change that would be helpful. So it's kind of a little bit of a triage, isn't it, really? But what have we been hearing about over the last 6 months to 12 months? We work across Hertfordshire. So the way we stratify our data is by the type of services provided. And a lot of what we're hearing about this morning, patient's story, about continuity of care, about being heard and listened to, feeling that there's something compassionate about the way people are engaging, and waiting times, and navigating the parking lot, and things like that. All those things do come up in the way that we hear from the public about acutes in our area. And so the fact that this isn't a surprise to you might be a bit of a validation of your knowledge and insight of your own communities, but there are other things that might need to broaden the way we think about it as a system, because now that we're moving from hospital into community and looking at integrated models and more neighbourhood models, we then need to think about what people's experiences of GP practices feel like and where there might be disparities. And we work with primary care team leads in the ICB to share that information. And things about feeling like care needs to be trauma-informed comes up quite a lot. We had Joe Maravich from Hearts Mind Network give a speech at our AGM recently and talking about how people experience these waiting spaces and first interactions in community spaces and how they can shape their entire experience of getting the service provided. So there are sort of these little dots that we need to connect across these. And we do also hear about mental health services, and over the past year since I've been Chief Exec, that has been increasing. So it reflects the systemic. Now, Neil mentioned we also do research and engagement. It's not academic research, it's action research. We do quick spits with specific communities about specific issues so we can feed quick insights into the spaces. We work closely with the University of Hearts where we can about deeper, bigger pieces, larger samples, but actually when you need an action plan for something, talk to the community it affects. And over the last sort of year, our program has had Hertfordshire-wide issues, things like a piece of work from children and young people, aging well, is how we are framing some of the language. It was interesting to listen to the frailty piece. We've just done a piece of work with Primary Care Transformation Committee, talking to the clinically severely frail, so the 8 on the Rockford score, to see about their engagement with hospital homes. Do they know about it? Have they ever seen the digital toolkit? No, mostly they haven't. And mostly they don't want to talk about advanced care plan or any stakeholders. So this is where we really go out into communities and talk to people. But we also focus on health inequalities. So we've done a really powerful piece of work with refugees and asylum seekers that has already taken massive traction in Hearts County Council, shaping the way that provides services that might be more accessible to all of our residents, like multilingual explanations about what our care system looks like. In some countries, you just go to your gynae, you don't have to go to your GP first. And that might be a simple thing, but actually the way we're moving care closer into community, there might be things in that space to think about going forward also. There's a list of other things, armed forces, we've looked at smokers and what works in terms of prevention, and I know you had a lot of interest in that before. Navigating drugs and alcohol services, and we're reaching out to the deaf community at the moment. But what we're hearing broadly in a kind of golden threads throughout all of our work are these themes around the cost of living and external things to people's health that actually influence their ability to live. So how far they are from services, how much it costs for transportation. On Aging Well and Proactive Care, Age Friendly did a huge survey. Thousands of people responded and said, there aren't enough benches for me to rest along the way to walk to town, and so I don't go out of my home. Now, talk about prevention and what interventions we could bring. Accessibility is still a massive challenge. We hear a lot of people about appointments within working hours, transport, BSL access. That's a huge thing that's coming up, and that's why we're working with the deaf community. And then long waiting lists and delays, which I know as a system is a lot of work going there. And then there's something about holistic and personalised bespoke approaches that comes out in all sorts of ways, but the case study this morning was so powerful in illustrating what that can do in terms of outcomes, which then translates into pound signs. So we work a lot with local partners, and I wanted to just take a moment and spotlight that there are changes in the system, but as Neil said, we're just around to help where we can, before, during and after the transition, whatever may come. We have so much insight and connections and networks be a pity to lose them. So we try to bring in everywhere we can. We go to a lot of committee meetings, don't we? But we also work quite closely with the voluntary sector, and I was curious about the discussions about your new building space and wondering whether or not a citizens' advice clinic might be on site, a mental health intersect, something with the voluntary sector, a hub, because people are more and more expecting community services to be connected to healthcare services, and if we could pick them up. We had a piece of work on cost of living 2 years ago, and it created enough evidence of people's experiences of how mental health and cost of living were connected, that we were able to help support a co-creation of a mental health support and a money advisor unit in the same space, co-located, and it made thousands of people's lives better. So it's thinking about how we connect with various partners, and that's where we can bring value and connections and networks. And we also do some co-production leadership. Some of you might know I chair the Community Assembly, which is this partnerships, HCP's Community Engagement Forum on behalf of the Healthcare Partnership, and working very closely with teams in this organisation to bring community voice into spaces. But I do the same in South and West, and we support a number of other co-production boards, and we help shape and design what those boards and communities could look like for maximum engagement. I've put a few things on our recent impact. I won't go through the details, but you will see strategies, plans, needs assessments, big investment, pound dollars, and then just like toolkits for professionals that have been engaged with, and making sure that people understand what helps people navigate the system better. We've done a lot of work on cervical screening and gynecological support services in the past year, and we're doing that quite heavily with post-diagnosis autism, so people who find they have autism in adulthood and thinking about the support, wraparound support in that. There's work going on that. And we have a stream of drugs and alcohol and addiction services and various kind of interrelated pieces. So I just wanted to finish on the last slide, which I'm very proud of, because I can only take credit for 1 year of this. I put both the last year and the years that precede me about the numbers of people who engage with us and the kind of time and investment we put in. Yes, we're publicly funded, and I think we deliver public benefit and more. So thank you for listening, and we'll welcome any questions that you might have today.
Thank you very much. I can see hands going up incredibly
Here we go.
Teresa and then Justin.
It's just to say a massive thank you, Ivana, to yourself and you for the work that you've done, and just to give you a segue into some of the work that we're doing that you've, I think, did the groundwork for, and sort of the ASL work. So we've got a project, I think I've been starting very slightly on working with deaf patients and hard of hearing in the community to work out how do they get access to care, not just whilst they're in patient, when they're an outpatient. And the brilliant Dr. Vaughan Barlow is supporting that as well. But really, the evidence from that came from the seminal work that we did in the national research. And then the other point I want to make was your work around military personnel, reserve services and their families is absolutely phenomenal. It's going through our network for military personnel as well. And tonight I'm at the Hertfordshire Army Reserves meeting, I think at 7:30, where again it's going to be discussed. So please note your influence is far and wide across Hertfordshire. And a final point, your team is very, very good at holding the minute up to us as an organisation, where we don't quite get it right, but where we have opportunities to get it right. And I absolutely can't thank you enough, and Alice and the entire team for doing that. And your voice of the community is really, really well received. That's all I would say, Jenny.
Thank you very much. I'm Nina John-Bill, one of the non-executive directors. I agree with Teresa, the report is amazing. It just really does demonstrate the amount of work that we do. For us as we're starting to plan for the next couple of years, do you think there's anything that we should think about based on the information that you've got speaking to the communities that we can make really some of our planning?
Do you want to maybe expand on the point you made quickly about the relationship with community services, and I might then on is there something about these actually undefined duties that the trust will get?
See the tag teaming there? I think from my perspective, trust is something we talk about a lot, and it's interesting reflecting what people have fed back to us and some of the announcements around what might happen to Health Watch is this kind of a sense of anticipated bereavement of the loss of that link because it takes a lot to trust people. And what we've learned from talking to communities is that it sometimes takes very little to break someone's trust and takes much, much longer to rebuild it. And sometimes you may never get that back. So working with grassroots community connectors is one of the ways that we managed to deliver some of the work we do. So with the armed forces community, we worked with people who were more grassroots in that. With our refugees work, we went to the charity, was on the front line of that. That's the way to get into safe spaces to hear from people. And I think the world that we live in is such that if we think about accessibility as a baseline, then everybody benefits. So the way we think about systemically how we include, say, patient voice into your spaces, into your decision making, if you take the view that if we make it easy for everyone to participate, then everybody will. And that's the way to sort of almost frame that philosophy. So the things I can advise on are things about systemic level changes and then even principles. So how do you get assured that you're hearing from people? How do you measure good engagement? How do you know that what you're getting in your kind of acute spaces matches with what the community thinks about your acute? And what do they know about you? I mean, I'm listening to what's been happening here this morning and it's phenomenal. And to your point, I don't think you toot your own horn very much because I don't think my neighbour knows that. She only knows the paramedic who showed up at her door. And there are different ways to get into how to, there's a huge hearts and minds change about to happen around prevention. And in the ageing world we are in, hospitals are going to have a different common strategy. So those are a few kind of high level things. Apologies if I've pinched any of your thoughts there, but we do tend to be on the same page often.
Unfortunately, you haven't. So,
Okay.
yeah, so just to add to that, I think there is going to be a challenge for trust boards around the really welcome stuff in the plan about improving patient voice and improving use of feedback. It comes back to what Adam was saying in his report about the fact that the delivery chapter was taken out of the plan. That's one of the bits where there's least indication from the centre about what it really is they're expecting trust and integrated care boards to do. All we really know at the moment is that there will magically be a connected web between you, the ICB, primary care, community services, health watch functions will be part of that. Patient participation groups will apparently be part of that, but no one's been given any indication yet about what the ground rules will be for it. And also no one's been given a picture about quite how little resource you'll be given to do that with. So it's going to require the kind of really smart thinking that Ivana was just talking about. And if you put local government reorganisation into the mix there, because in another bit of the plan, there's, with integrated care partnerships going and beefed up role for health and wellbeing boards, and then have them having more grip on plans at kind of place level. There's going to be quite an important dynamic there in terms of that community involvement. But I think the real risk for trusts is seeing that the plan talks about the app, seeing that it talks about kind of beefing up mechanisms like friends and family test, having that kind of instant, very data-driven feedback, and that distracting people from the stuff that really gives you the insight, the kind of thing that Teresa was just talking about, the stuff that helps you understand why the numbers are the way they are, so you can do something about it. And that's the bit where what Ivana said about having trusted mechanisms that people people often find, and there's a lot of academic research to support this, people sometimes are scared to say what they really think in case it affects their care or that of their loved ones. But there are also a lot of people who know that staff are hard pressed, under-resourced and really busy, and the last thing they want to do is criticise them. But the organisation really needs to have that. So having ways that are not necessarily knocking on Adam's door to make a complaint, for you to get that richer contextual information is going to be really important.
So I also wanted to say how appreciative I am of the work, and Teresa said it far more eloquently than me. I think the real challenge to us as an organisation is how do we keep the stuff that really matters in this, and how do we do the work that matters as time goes on, whatever the structures that come centrally, how do we do the stuff? I wanted just to pick up a little bit about your point on CAB, So we were lucky enough as a board to do a board seminar on poverty and the impact on our population at our last board seminar. And as a result of that, the chair has asked me to go away and produce a paper for the next board seminar to look at what our responses to that could be. I just realised I'd missed an opportunity in writing that paper, but it's not yet submitted. So if it's okay, I'd like to share it with you and get your input into it, because I think that there is a lot that we can do as an organisation to support our population better. Much of it is not going to cost large amounts of money, because that's important at the moment. But I think there's quite a lot to do, but I wonder if we can work together on that and looking at.
Support. I mean, this is our kind of mantra, really, is if we can work in partnership, then we get better result, don't we, really? And I think, just as an example on ageing well and frailty, we're going to do a piece of work with partner ECCPs this year to pull together the resources that are provided by hospices and different websites that are Hertfordshire specific, so people can go to one place and find out what affects their care in their actual locality. Because there's a lot of national resources. It's not going to cost a lot of time or effort. It's a little web page that's being updated, but there is no one place where one can go for this information. And it's going to be on Educare's website, and we have things like advanced care planning and a workshop on benefits and so on. So yes, happy to take it on, and any way that we can help that we can think of, please put us in.
Right, we've got Amy, Stuart, and then Adam, and then I think we will have to bring it to the close.
And I just wanted to reassure the board that as we're waiting for further guidance on how these duties might be kind of split up, the Van and I are meeting tomorrow to start. We've already started those conversations, but just to try and sort of get a head start on that and work out what that engagement might look like. And we are obviously working across the healthcare partnership area as well, so with community and primary care. And I think we're both agreed that one of our really key principles is really not to duplicate things that are already out there, so not to try and create new channels, and also not to overburden groups that are consistently asked for their opinion, and just to really show the evidence. And just on the Citizens Advice Bureau, so I've also been just looking at how we might be able to reinstate our community hub, which we had pre-COVID on the main corridor. So I've been doing a bit of work on that, so I think we just need to make sure we're all a bit linked in there.
I'm one of the members of the Voluntary Sector Alliance, so I can link you in by that route to be helpful on the steering group.
So one, I really value a conversation with Ivana, thinking about the governance and around the HCP and what we can do to protect what Health Watch has built. The second point, which I was going to make, was around culture. And one of the things, so we've just got these new league tables, which puts a priority on financials. And one of the things that Health Watch does is it's early warning around things. It's holding to account. And for us as a trust, one of the strengths, it's just my personal opinion, is around a non-blame, transparent culture. I'm not saying everything's perfect, but it becomes even more priority when you don't have a Health Watch. So the next Trust Board seminar will be talking about culture, and I think there's possibly an opportunity there to cover this.
Could I just add, one of our key messages, probably for the next 18 months as well, is that none of the legislation changes necessarily means that there won't be a Health Watch Hertfordshire. We're an independent charity. The government doesn't get to decide, unless it passes a whole separate law abolishing charities, then we cease to exist. What the government absolutely will do is change our statutory duties and the statutory commission responsibilities, but there are lots of scenarios where we could keep existing and supporting the system and delivering some of this stuff. So don't give anyone the impression that we are automatically shutting up shop on a given day. It's far from it.
I think Adam has just said that.
Amy made my point, but in the 10-second version, even the example, for example, setting up debt advice or whatever, the importance and why we've agreed, particularly with HCT, we would look to do our engagement and work together, is that we could set one up and then find that HCT have set one up half a mile down the road. and there's not enough activity. So the point of already working on saying how do we hear our patient's voice, and it doesn't matter whether that patient's pitching up here or in primary care or community, let's do it once and do it well.
So thank you very much. As you can probably tell, we could keep on. There is so much that you bring that's really helpful to us. So thank you very much indeed. We are going to have to move on. I'm afraid we're going to move on to the bath after that. So off you go, Stuart.
Thank you very much. Before turning to Lucy and Mark on the 2 spotlighted baths, I've presented it as a partial assurance rating reflecting, as stated at last board, there's a lot of new risks added on here. I'll probably add to Richard's point earlier where he's saying actually we've also got a lot of priorities. So you're seeing a lot of senior execs who are diligently trying to mitigate these baths, but equally there is a stretch. There weren't any committees in August, so FPPC hasn't had the opportunity to consider this, but Adam's briefed the board about some of the changes around the system, and therefore there will be a proposal brought to FPPC around increasing that the system instability score. Those were the key things which I was going to highlight, so the paper sets out the other points. Before I turn to Lucy and Mark on the spotlight backs, were there any other points that people wanted to raise in that? Okay. So if I turn to them in order then for the cancer bath, Lucy.
I mean, people can see the updates that there have been, and I think in the interest of time, I'll just open it for any questions or comments.
Are there any questions or comments? Adam.
So it references the oncology service at Watford, and now we've been doing some interviews at the moment around strengthening that service. Are you content that plan is coherent and West Herts are engaged in the way that we want them to be as partners on that?
I'm thinking as far as we can expect at this stage, yes. It doesn't mean we don't need to continue to work with them, and Martin might have some more comments he's closer to.
Yeah, I mean, certainly it's been a service that we've been talking about developing for over a year now, and then HSE have put some specific funding in to enable that. At Camp Watford, I think it's taken a little bit of time to get the recruitment going, but having made a series of kind of appointments in there, I think it is an important step for us in terms of addressing what is significant clinical risk on this. I think it's great progress.
Okay, thank you. And then looking at digital transformation risk. So since the papers were drafted, there's been discussions between Richard, Anita and Mark about the one EPR committee, which is currently just on one EPR and moving into a broader sphere, so becoming a permanent committee rather than task and finish, broadening to cover all of digital and meeting monthly. So just highlighting that to the board, and the proposal will be then brought forward to the next board for terms of reference.
Yeah, so I mean, following on from that, then the digital transformation BAF relates directly to the one EPR deployment. I've still retained a risk score of 16, and that mostly centres around 2 items. One is engagement, and the discussion currently is around training and how do we release our clinical workforce to get training in place. And the other is obviously that given that the funding from the Frontline Digitisation Programme was minimal and we funded this project through trust cost pressure, then I use substantive staff for this, and obviously CIP is then poses a risk to some of the funding around that project and continues to do that. So I think the main mitigation now is the formation of the one EPR committee, and that's bringing together execs and non-execs to help support across the trust, and as Stuart says, we'll widen that remit. Any questions?
Did you have any comments, Richard?
No, I think we'll discuss later on the first report out of the committee. That's maybe the better place to do it. I think fundamentally what's in the BAF is reflecting what we want.
Okay. which is the next item on the So I think if we stop there and come back at 4:15, we can do that. Thank you very much. everybody. We're now moving on to the Workforce Disability Equality Standard Report.
Thank you. Disability and race, I'll cover both of those. Thank you. So just for clarity, there's a requirement for all NHS healthcare providers to measure ourselves against a series of metrics and to publish that data on an annual basis in October. So what you've got in the packs there is the outcome of that, the outcome of the most recent review. I think what I will say about both schemes, both disability and race equality, is we don't have a complete data set in either, which is something that we're working on, and in many organisations I've worked in, there's often an incomplete data set. So I just wanted to kind of set that out as what you're looking at is the data we have available, not 100% in terms of our workforce. If I start with disability then, overall the metrics that we measure ourselves against, looking at our performance from last year to this year, we've gone up in a number of those metrics. Some just marginally, but we have gone up in the majority. What I'm referring to here, and I'll take you through two main things. First of all, the snapshot of data, and then I'll talk about what we've been doing about that data. So on the snapshot slide, we have an outline of kind of different percentages against our different populations, so clinical, non-clinical, doctors and dentists. They look quite low. As I said, we don't have 17% of our data set, which is unfortunate, something that when I go to talk about what we're doing about it, it's always encouraging people to share data with us. Nevertheless, the more detail that we have when we start to break the organisation down into layers is we've actually gone up in our percentages of all of our different layers, bar one. And the bar one is the senior manager population. And this is reflected, in disability and in race. The more, I would say this is a general statement, but I think it holds true. The more senior you are, the less diverse the population. And that's something that's come out certainly from staff network groups. I think that's shown here. In terms of experience of our disabled colleagues, we found that a disabled member of staff was 1.5 times more likely than a non-disabled member of staff to go through a formal capability process. So where their performance conduct is falling below what the expected standard. And I think there's something to be done there in understanding why that is. It's not just because, there are a number of different variables in looking at disability. It's really important for us to understand the different types of disability and how we can support people. There's quite a high number of our colleagues who have said that they've had reasonable adjustment, 76%, but clearly there's something going on there that needs a bit more kind of discovery work as to the conditions that people are presenting and how as a trust we can support them with that. Worryingly or disappointingly, we have 32% of our disabled staff have said they've experienced more harassment and bullying from patients than they did last year, and it's gone up 4 percentage points. And I know that's something that, as an exec, we've been talking about, violence in the workplace. So it's not something that we are not alive to, but that is quite a stark figure. Having said that, overall engagement, we've looked at our staff survey. Overall engagement has marginally increased, so we're now on a par with the national average. So overall, there's work to be done for this population to understand some of the metrics, to be a bit more proactive in what we can do against some of that understanding, and to support our colleagues even more, certainly in the front-facing areas. So if I just, I'll stop after the actions. If I just talk you through some of the things that we've been trying to do in this space, and then I'll pause for comment. We do have an ED&I steering board, and we do have a 3-year ED&I strategy. We're in our 2nd year. I think if I were to sum up what we've done in this space, I think we'd like to have done more. So I joined maybe 8 weeks ago, and I think one of the first things I landed on is we haven't done anything with the team. We know there are gaps, but you need to plug those gaps. ED&I is one of the things that I think we're perhaps lighter on that needs a bit more focus. So very, very aware of that. Having said that, I think that's then impacted the ability of my team to be able to do stuff around this area. But we are going to look at I think that the ED&I strategy is still very fit for purpose. If Diana were here, I'm sure she'd agree. Hopefully she'd agree, she chairs the ED&I steering board. But we just need to motor behind what we're actually doing against it. One of the things we do have is a very active chair we have our staff network groups, and Kevin is the chair of our kind of enabled group. And I think working with those groups can give you a really rich idea about staff experiences. And actually they're coming forward with, and this is what you can do about it, so it's not just presenting a problem, that's what you can do. So I think that if anyone were looking at that slide thinking that looks a little light, I would agree. And I think that's the resources I've had available, or the trust has had available so far, has maybe shaped that, but we're very aware of it, and it's my desire and intention to do something about that moving forward. So I wonder if it's a good opportunity to stop now before I move on to race and just ask for reflections or comments. David?
Well, thank you. I listened with interest, and I do think we probably should and could do more in the area of disability, and I just want to focus on the fact that every board I work on, whether that's charities or this NHS board, is that we struggle with that. Even the stroke board, struggles to see how it should engage properly with people who suffer stroke. And last night I spoke to a doctor in his 20s who had a really nasty stroke 4 years ago, and his final is really with it mentally. He's not part of this trust, but his employment has now ceased because they can't find a way. And I was just thinking to myself, what opportunities have we got to help this very, very intelligent young person? And I struggled to think how we could help. So just some general comments about the genuine difficulties, but that doesn't mean we shouldn't try a bit harder.
I was surprised the other day. I had the NHS meeting. I was surprised at my complete ignorance around those people who actually declare their disability, and I was shocked actually from the story that we were hearing there. I've asked the person who did that story whether or not they'd come and see me and maybe come to the board and do it. It was an eye-opener for me, and especially around how many or what was declared as a disability and how people view it as an obstruction to potentially getting additional work or being trusted at work. So I think it would be useful. I will speak to people about whether or not that can come to the board. The second thing was on the violence and aggression. I looked at, and unfortunately the thing I looked at because of the violence and aggression I'm involved in, I'm not sure whether or not that number is in line with non-disabled personnel as well. I think violence and aggression is just becoming more, or the positive swing on this, which is not really positive, but what I mean is they're being declared more, people are actually identifying it more, and we are getting more and more reports on enhanced disabled or non-disabled personnel being bullied or harassed by patients and relatives, and I think the relatives is even worse. So a couple of items there which, as I say, until I was at the NHS meeting, didn't come through as much of a shock as it should have done, really, tuning out.
Richard?
Yeah, well, one is a detail, one is building on Kevin's point, really. I'd be really interested because we compare percentage of disabled staff with lots of things, but not with our population. And I'd be interested in, do we have a proper reflection of our population? Maybe the more important thing builds on what Kevin just said, and I think the theme comes back at race as well, right? So when we talk about harassment, bullying, abuse, to me, this sounds like a really significant issue. And I'd like to see more action related to this specific issue, and it's in both networks really that we talk about. And I think we also highlighted it when we talked about the employee survey.
So also picking up on that point around harassment, I think what would be interesting is to understand if the harassment is different for different characteristics. Because then we know whether we need a
a policy that covers everybody, or if there are specific things that we need to do to target the way that specific groups are being harassed, because I think that's obviously incredibly important, isn't it? Because then we can start to look at what we're doing.
I think, I think a lot of this is down to frustration and instantaneous gratification issues that people want to be seen yesterday, which is unfortunate, it's not the way of the world. But everything I see now is frustration that's coming out, and just civility has gone, unfortunately. So I don't think it's spread across this. No one is exempt from this, I'm pretty sure, from top to top in the whole of our organisation. So I'm not sure, but it would be interesting to do some background work on that. We can get it from the figures we've got. I'll speak to Penny about it.
It's a small point compared to the ones we touched on, but it's because it's one of the few reds on here, which is about the essentials of the board declaring. And I'm very conscious that we had a session on this probably 2 years ago, and we broke into small groups of 4, and in the group I was in, 3 of us identified that we had a disability, but none of us had declared it. So I've now declared my disability on the system, and I think we reflected a bit that if you don't feel you need any support, what's the point in doing it? But I think when we talk about our role as a board, there is a bit of role modelling, and I think we should make sure that it might be that 11 and 29% is the level for our execs and non-execs, and it's a relatively small group we're talking, but I suspect, I have a hunch that not everybody is necessarily declared, and I think there's something that we can role model that before we expect others. I want to know why 17% haven't declared. Well, we might be part of the problem when they're for the use of that.
I think that was a really interesting session actually, and I remember what Adam was talking about, and there was lots of reasons why individuals haven't declared, and it all makes sense, but I think it's actually really important way to get more modern as well, so perhaps one for us all to take away and reflect on.
Nina, so just one other thing, so around the recruitment for more senior roles, is that going to get picked up by the people committee in terms of further thinking action plan?
So Penny, I think we're back to you on race.
Yes, thank you. So similar applies as a requirement for us to measure ourselves against a series of metrics. There are 9. Mixed picture, really, we've improved compared to our performance last year. We've improved on 5. 1 has more or less stayed the same, and 3 has deteriorated. So we still don't have a complete data set in this one, but it's less stark, it's 6%. I think overall, our performance in terms of, sorry, just to say before I continue, so we've referred to the term BME in this. Typically, we would say ethnically diverse colleagues, but the standard itself requires us to use BME, so for consistency, I've used that in here. So just from an overall composition point of view across the trust then, from what we know, we've gone up from 40.8% of our colleagues as BAME to 42%, so it's a marginal increase, but it's an increase. I think the same is said for race as disability. The more senior, the less diverse the population. And so just to pick up your point, Neil, this is definitely something we'll be looking at in terms of I'll come in a bit more detail, but talent management, how we encourage people career pathing. So there's definitely some work to be done. We are a diverse organisation, but less so at the senior levels. And while it doesn't necessarily reflect promotion, we are seeing, because we do lots of evaluations of our recruitment campaigns, less number of BAME applicants being appointed after shortlisting the white candidates. So there's something there, even though we are providing inclusive resourcing training, we're ensuring that our panels are diverse. Yesterday I met for the first time our race staff network groups. I've just taken over as exec sponsor for that group, and had really interesting discussions around cultural differences and around, in some cultures, they don't put themselves, it's not the dumb thing to put yourself forward. Mm-hmm. That may there be impacting people, and they might need a bit more of a helpful nudge, or a really encouraging, you're good for this, why don't you go for it? As well as our interview process as well, making sure that we're actually continually monitoring them for any signs of bias, maybe, obviously indirect, but whether that's happening. A couple of other things. I'll finish with I'll finish the deterioration and I'll go into the positive, so we end on a more positive note. There's been a deterioration of our BME staff as well, with experiencing harassment from patients and relatives. And yesterday, there was some views shared with me about the increase in the St George's flag appearing everywhere, and just how staff felt on their way into work. And some of them saying, what's this all about? Others were saying, I know what it's about and it doesn't make me feel safe. And I think it's just those kind of we had a discussion around wider societal issues and what our role is and how we can support, what can we do and what's a broader issue. But it was just interesting actually that I think staff felt that with the issues last year and the riots and the riots in Epping, the tension had increased and therefore they felt less safe. And some of the ideas they were talking about was flexibility in terms of start times or, how people experience work, so they're not lone working and stuff like that. But it was really interesting to hear their perspective. It's something that certainly I would never pick up on, but they were feeling it quite keenly. So that I think is a really interesting insight, and I'm following up on them in some of the things that we might do on that. So that's the deterioration. Just touching on some of the improved areas. We're looking at likelihood of colleagues entering into formal capability processes. We've improved on that in that BAME staff are less likely to move into a formal capability process than a white member of staff. And actually, and this came out yesterday, are more likely to access non-mandatory training. So it's an interesting one. You've got people willing to put themselves into positions where they're accessing training, sometimes, in their own time, furthering their own, but it's still not translating into them being able to progress their careers, which they talked about wanting to. So there's definitely a few metrics we need to triangulate there and understand what's going on. As to the staff network group did have some fab ideas, so I'm certainly going to mind that. I'm going to use this opportunity as their exec sponsor to get some insight into that. Just in terms of next steps and recommendations, as I said, we've got an EDR strategy and we have a steering board, but the amount of push behind that has been limited by the amount of resources I've had available, but that's something I'm looking to work on. The other thing that I'm really keen to do with all elements of EDI is to kind of map out the employee journey from when they're attracted to coming here, from assessment to performance to development, and mapping all the way through and looking at an EDI lens, because I think that tends to have better success rates and it's more sustainable than something that's just a bolt-on. So it's certainly not saying, well, we all do it, so let's not focus on it, because I don't think we're in that space. Clearly, we're not looking at our data, but it's certainly looking at the employee journey and mapping out where could we have an EDI lens, and are we doing enough? And sometimes it might just be a tweak in a process, or being more mindful of language. That came up yesterday as well. So it's not always big things. Sometimes it's the small things that can make the difference. Just to finish before I take comments and questions. As I said, I've been here around 8 weeks. I've inherited like an interim team, and that was deliberate because decisions didn't want to be made before I came. A review is underway. This is an area that we are a bit light on, so I'm looking to strengthen that, as well as changing some of the offers into the trust. And what I mean by that is having a really robust talent identification, development and management offer into the trust, which I think has probably fallen behind a little bit in the last few months. So there are green shoots in some of it. It's not all negative. There are green shoots in some of our data, but I'm not oblivious to the fact that we need to do more.
And I think it's really interesting to see the detail in the report, so I just wanted to highlight you, because you're so new with this. There's a great piece of work that Lorraine Williams has been leading on for about a year. You might be familiar with it. It's called the Legacy Nursing Approach. And so really what this is trying to do is take really experienced, largely speaking, possibly nurses who are at the tail end of their career who want support, particularly being nurses, to help them navigate and negotiate through the system to be able to get into those roles. And it builds on the 90-day challenge which we participated on last year with the ICB colleagues to make sure that there's an equitable platform for staff coming through. But there's some really interesting support networks evolving through that legacy nursing. Very small at the moment, but hoping to move into maternity and AHPs as well.
Okay, I'll take just one more question because we are running quite severely behind, if you don't mind. So Nina, please.
I just want to say I'm really glad that you raised the thing about flags, actually, because that's one of the things that I was going to ask you about. I've got a friend who lives in St Albans who came to Stevenage to pick up some things, and she said there were flags everywhere, and she couldn't wait to get out of Stevenage. So if that is something we can start, it would be really great. And just obviously the only other thing is the fact that, and I don't know if you don't have the data for disability around useful staff.
Yes, we do. Yeah.
Oh, okay.
Yeah.
So it wasn't in the cabinet thing, but I guess that's one that it would be great for you to pick up as well.
Yeah.
Sure. Because within ourselves, we should be quite dignified towards each other. So, there were just 2 points I wanted to raise. Thank you, Chair.
Thank you very much indeed. Thank you. I am now going to move us on into the integrated performance report.
Okay, thanks, Chair. So I'm going to lead in terms of taking us through the domains and then open up to questions to the SMEs for those areas. So if we start then with the quality domain and kind of more or less a standstill. So VTE assessments have improved, which then obviously improves in terms of treatment of sepsis. I think that's going to be an interesting one to watch because we know that the kind of the VTE process at the moment is kind of cumbersome with our current digital systems, whereas the new systems is going to actually mandate VTE, so that will be an interesting change that we should see next February, March time. Crude mortality has showed a slight increase, but not statistically significant at this point for us to draw anything from. Interestingly, the stroke SNAP rating has fallen to E. However, the performance has actually remained consistent from last month. What has actually changed is that the reclassification has changed and therefore has taken us down the rating. Obviously a lot more work to do on that now to bring us back up to that point. And complaints have changed slightly as well. In terms of people, is bank and agency staff has increased. I think we mentioned earlier that the variable pay event early on in the month or last month in fact kicked off, and a number of work streams have been taken from the VPE specifically to tackle bank and agency, so we should see those ramping up over the weeks. Sickness and mandatory training and Grow Together has improved, so I think that we're not far off of the target, but I think if we compare ourselves to other trusts, then we're kind of down those ranking lists, so that is absolutely something that we need to resolve. And in terms of the MARS scheme, then we've approved 15 members of staff for MARS that will leave shortly, but still there's 72 behind the plan of 50% of the increase since 2019, still 72 people that remain there as part of the CIP programme. In terms of finance, then...
Can I just stop you there?
Yes.
Just for a second. We are going to get a bit confused over some of the topics. Can I just get David to come in, please, on quality and safety first? Then we'll go back onto people and then we'll just track through the minutes. Is that okay?
Okay. So thank you, Mark. And as far as the board is concerned, some of these issues that you covered are also covered in my QSC report, so I won't duplicate those. And a number of things like fire safety are appearing this month in QSC. So the 2 things I would probably touch upon, just to go into a little bit more detail, that may come up at other times, are complaints and strokes. So I would reflect that complaints or timely dealing with complaints in particular have been an issue for us off and on for some time. We did see considerable improvement a few years ago, but for the last 7 or 8 months, the number of complaints has gone up, and some of those factors may be beyond our control, but we can't ignore the fact there's been an increase, and the report is accurate. In fact, this month it's slightly down, but that's on the back of some high numbers. So that's just a sort of accuracy. The second is just to bring up the issue of stroke, and public board, so I would just remind everybody that I'm vice chair of the Stroke Association of Charities, and Mark, I completely agree. I spoke to the medical director who organises SNAP, and many trusts, if not the majority of trusts, have been downgraded due to the fact that the annual audit had just simply been made tough. We can't ignore some underlying issues, but while our thrombolysis rate is 10%, areas, hospitals of excellence, are achieving 15, and we could go further, and our thrombectomy rate remains lowish, low at 1 or 2%. Again, that the national aim would be to get that much higher in the long run. So I just want to put that perspective in there. But otherwise, completely agree with Mark's.
Thank you. Are there any questions on
just to highlight the work that's been done in PALS and complaints data. So we've got a real granular picture by division, by specialty, by service line, and that's circulated to the divisional nurse directors, the director of operations. They're all aware of it, and we've got a real peak in plan care, so that's where the tension is, and it kind of goes back to a point that Neil made earlier about people who are trying to get appointments or waiting, so we know where the issues are and it's targeted. And in relation to PALS, because there's a parallel there, it's having additional people to be able to make sure that those calls are being fielded. But the really important thing is getting to the heart of the matter and preventing the recurrence, and that's the work that we're going to do with divisions. And as we get into the divisional work, the QAC will see a bit more of that triangulation.
Can I just acknowledge the work that Teresa and others are leading? PALS has been a tricky issue for all of us, but it is up and down at the moment, and I just opted not to bring up that subject again because there hadn't been anything dramatic to report to the board, but certainly the number increases that are not, there are no big number increases.
Just around stroke, what would be nice to know is, has everybody dropped 3 levels? Because we've gone from a B to an E. So is that a national picture that most people
So the reply was 80% have been downgraded, not necessarily from B to E. I don't know how accurate that figure is, but more than half, the majority. So I'm just trying to acknowledge that, but also recognise that we still have challenges.
Thank you. Thank you. And then we'll complete on people next before we move on to finance.
Okay, and actually just as complaints was kind of a topic, I have engaged with the complaints team around trying to use AI in a sensible way with a governance wrap in terms of making it more efficient to responses to those letters. So do you want me to move on to people then? So again, I've gone through most of the aid, but just to recap, that was really around the bank and agency spend increase and the variable pay event in terms of trying to mitigate those. Sickness and mandatory training, grow together training, although they're almost as close to the target, is that those are things that we need to pick up on and improve on. And 15 people have now been accepted under MARS, but that still leaves us 72 under CIP to bridge that gap between the 50% of increase from 2019 to 2024.
Just picking up on the piece around occupational health and the number of referrals, been a significant increase of managers referring people, which I'm just wondering how that might correlate with the amount of change that's going on in the number of people being consulted around changes in services or potential redundancy. And kind of that combined with the fact our turnover rate's gone down, which I think is a kind of national picture across all sectors, actually just something we ought to be mindful of, because if our sickness starts to also then decline, that's going to put additional pressure on services. So I just don't know whether you have a view on that, whether it is stress related, the occupational health referrals.
I would say that sickness absence in mental health is going up. This is also though we're starting to manage absence more closely, and so we're on to managers to do things in a more timely fashion. That's also reflected in there. So sometimes an occupational health referral can be really helpful early on. It's left for 3 months and the person is in more dire need and they're not in work. So we're actually encouraging managers to adhere more closely to the policy. So that's also in that figure. Richard.
Yeah, I've got one question. It's related to what Mark has said, that, and we've discussed this more often, but we've got a really low vacancy rate. We've got a low attrition, which is in essence a really positive thing, and yet we are not able to decrease our bank usage, which is kind of double the target. What is the problem?
I suppose overall, I would say it's we don't have a capability for longer-term workforce planning. We don't have a robust workforce planning capability. Bank and agency are easier to go to if you don't know what's coming and you need to fill gaps, because we obviously need to keep services. So, I mean, you're leading on some job planning stuff, I'm leading on some stuff that came out of the variable pay. It's basic. I think it's grown over time. It's a lack of planning. It's also looking at rostering and make sure that we've got robustness built into our rosters. But it's also then governance. So something that I think Lucy, Justin and I are about to pick up is almost like a weekly review of bank and agency staff, and do we really need it, or is it just an easy go-to? So I think there's a number of contributing factors.
I guess just a supplementary question to that. Sometimes it's a behaviour that you see when it's easier to get a bank or agency role approved, when it's made more difficult to approve substantively. And I guess it's just maybe in the process of looking at that, just making sure that we're not actually getting in our own way by not appointing something substantive and then pushing up the agency spend.
I guess we need to really also understand the aging of the bank staff that we right, so there's probably going to be more conversations on the private side.
Justin?
Just a brief comment from a medical perspective, we need to be slicker about making sure that when a vacancy arises that we get on to fill that vacancy with a substantive staff member so that we can avoid that bank and agency use. And there have certainly been examples over the last year where we've not been as quick as we should have been to do that, and that's led to increased expenditure.
I was going to come in and just to support some of this inertia from the management. I'll talk from my own side that once someone's been put into a bank position with all the other pressures, there's a wiping of the brow on everybody and sits back. And I think that, that it's being timely told, especially at our board, you now need to review and go back through them all. So that inertia, I think, we'll see if we can move that. We'll get some way of bringing back on those bank and agency, because it's a harder piece of work to full-time employ and appoint. So, and I think that's on that side. These figures are clearly identified.
I think so. The challenge that Richard's picking up is we are still successfully recruiting, and we've not seen the fall in the bank and agency in the same way with increased substantive. And I think for some of the behavioural issues people have described, we're used to using that, so people are using bank. We've got some particular areas in midwifery. We know that there's a very high maternity leave rate at the moment, which is kind of ironical, maybe not ironic, but so we've got a higher level than would have been factored in. So even though we have substantive people more off at the moment, I think there was a drive around some of the sickness things as well, so we needed to cover. But we also picked up through the variable pay work processes around our clinical support workers. And because we have an inbuilt delay of saying you've got to get a post approved because it's a funded post, rather than having a rolling programme where we know that is one part of the workforce that are turning over, let's continue to recruit. And what we shouldn't do is take too much assurance about some of the retention, because although we've made some active strides to do it, it is across the NHS, and it's part because everyone is downsizing, so no one's moving on because there aren't roles to move in. So some of it is fortuitous, which means we need to be mindful that when the market opens up again, we are really keeping people because they want to stay rather than because there's no alternative.
We've got Martin and Alice.
I think I've said very much what I was going to say. I mean, I would just I'll just comment that there are more than 100 additional substantive staff in the organisation today than there were 12 months ago.
think Lucy's point.
My point was about the parental leave.
And I would follow that as well in terms of the admin side, is that with the outpatients consultation work we're doing is that we've held vacancies open, filled them with bank staff, and once that consultation goes through, we will fill those with people whose roles have moved on. So we should see a dip coming from there.
So I apologise to you, Mark, because I know I was really by making the break off and start again, but we're now on to finance.
Yes.
Thank you.
Okay. So just a couple of points then in finance is that we obviously had industrial action impact at the end of July, but we're still reporting an 8.6 million deficit, which is in line with our expectations. And then linked to that, the CIP plan assumed 4.3 million at month 4, but then recognising that is a significant ramp up for the following quarters.
It pretty much says it in the finance report, but it's maybe good to comment on Mark's immediate remarks. Yes, that's correct. We are reporting, let's say, on plan, but we've used some of our reserves to make that happen, and we have not identified the full, let's say, size of the CIP as we speak, and we are far into the year. So there's significant concerns. I know there's significant action underway, but I think that is one of the bigger risks we face.
We've pretty much, I think, gone through each of the chairs.
Operations.
Yeah, operations.
Operations. Oh, Lucy, how
and the operations is the good stuff, actually. So.
Now you're hurting some people, Mark.
We've seen improvements in UEC, so both 4 hours and 12 hours, so leaving us in, I wrote this before we got the 19 out of 134 rating, but we've got a 21 out of 122 rating in relation to performance of UEC across the NHS. 6-week performance on MRI has been a focus, and we've got new capacity in place, so we've switched to CT from an MRI, and we've got additional outsourcing in place. And cancer dipped slightly under the 62-day, but we should be back on track with that. We'll forecast for next month to be back on track with cancer. I'll leave it there.
Richard?
I echo Mark's words. I think we are encouraged by the improvements that we have seen. There were some concerns about some specific diagnostics areas, and MRI has improved. I think we still have non-obstetric ultrasound as a focus area. But other than that, really good improvements. RTT is moving in the right direction. So, yeah, positive.
Is there anything you wanted to add, Lucy?
No.
Thank you very much indeed. Okay, are there any questions on the performance side? Anything else anybody wants to ask? No? Thank you. So we can move on to health and care partnerships.
Yes, so we have this is the first time we're really now bringing in the Health and Care Partnership reporting to the board since we agreed to move into the new model where we are now accountable as a trust board. Just to remind people that this was set up in effect almost as a shell at the moment, because it facilitates the ability to delegate responsibility from the ICB to our trust on behalf of the partnership. There's nothing particularly I'm going to draw out that's not drawn on here, other than to say huge amounts of work is going on in the background, not least with some of the team here around the challenging planning horizon, and not just the normal planning horizon, but setting out year 1 of a new medium-term plan. And more will become apparent in the way we're approaching that, but also just working through the implications of due diligence, setting the good governance in place so that when we do actually take delegation as an organisation, we've got the appropriate measures in place. But But the final thing that's really important and doesn't necessarily always focus on a timeline because it's not as functional is the behavioural aspects, the culture, the really aligning with our vision. And we've had 2 or 3 workshops so far with partners across the system to really talk about what do we want the future to look like rather than who sits in the meeting or what lines on a diagram. So lots of work going on in the background, but nothing really to report of significant action change.
Thank you very much. Any questions about it? No. We've got the Audit and Risk Committee. Does anybody have any questions on that report? No. Richard, on to the Digital Committee.
Yeah, so the report was based on the first meeting that we had in July. In the meantime, we've had our second meeting on September 1st, so not too long ago. So I just like to make a few remarks based on that meeting. 3 additional risks that I just want to highlight. Mark is aware of them, we're working on them, it's not a surprise, but for us it's important. The delivery of the various software packages and the timeliness of the delivery and the quality of the delivery. In the end, this jeopardizes the quality and the timeliness of the functional workshops, so the way we engage our people and how they're going to use the system in their processes, and ultimately, of course, the implementation and the benefits realization. And then finally, this is what Mark has already mentioned earlier, the resourcing of the training, the UAT, and the implementation, which is happening in the winter period. And so I think it is really important we understand these risks, we try to mitigate, but we also are clear on the go no-go criteria, which we have agreed in the committee, and as early decision as possible about the implementation, because of the workforce implications.
Any questions for Richard? No? Thank you very much. We move on to the annual cycle, which I think is all clear, but we do have one item on any other business, and that is our winter planning assurance. So Lucy, thanks.
Yeah, thank you very much. We've engaged in winter planning earlier this year than in previous years, and you can see in the pack quite a detailed pack of where we are. It's a developing plan. We took the version as it stood at that time to FPPC in July. It's grown quite a lot, and quite a lot of additional information added to it since then. It's there for you to see. It was tested on a Herts and West Essex basis wide in a kind of virtual winter exercise last Thursday. So again, after these papers were put in, with kind of that was an exercise that had injects, as in challenges that are being tested nationally. So some of them are around personal protective equipment and flu levels in excess of what you would expect. So it was quite, there were quite hard tests. I haven't had a full opportunity to catch up with our staff who joined that planning exercise. So I can give more detail when we come to next FPPC with the next update of it. But the event itself was felt to have gone well and met the need in terms of testing plans of ourselves and system partners. All trusts being asked to complete a board assurance statement, which you can see there as well. It's with the drafted response suggested for it's to be in by the end of this month. So you hopefully will feel that you've been given enough assurance what's in front of you at the moment to agree to it, but we have a bit more time if the board feels there's more assurance required. We could take it through FPPC for that sign off or outside of the board with an agreement. So happy to both take questions and then hear views about the level of assurance you feel.
Of course, first of all, do you have any questions?
So I really appreciate the work and that we started earlier, and I think it's a good piece of work. Flu vaccinations, I think it'd be great to see some timelines and targets. We were 39% last year. We are obliged to be 5% higher, but I think we should be a lot higher to really make the winter period easier. The question on COVID, we just discussed it. It's increasing. You can see there's admissions with COVID. Is there a plan on COVID vaccinations? And then when I read the plan, to me, the biggest concerns are around pediatric and mental health. And those are the two areas that I think require maybe more focus.
Yeah, but perhaps Justin will say something about COVID and potentially flu vaccination, just in terms of peds and mental health. If you look underneath our paediatric UEC performance, it has improved massively, and at a higher rate than adult type 1 performance. That's not just because of seasonality in summer, which obviously is an easier time for peds because it's been on for long, and that's partly reorganisation of the doctor support in ED particularly, and better integrated working between the adult emergency medicine consultants and the paediatric emergency medicine consultant cohort. So I'm not saying that's sufficient necessarily, but we've got a much better baseline that we're going from. Our work with HPFT as our mental health trust, our collaborative working continues to improve. The relationships are much, much better. We've had multiple instances recently of working really closely on particular patient challenges. They are much more responsive to our requests, and I'm about to pull some data about how long on average our mental health patients wait in ED, and although there are still instances of inappropriately long waiting times, my anecdotal sense is that happens less regularly now than it did. I also noticed HPFT are, I've not seen their numbers, but they are much more responsive to paying for private beds when they need to at an earlier stage. That, coupled with the Mental Health Urgent Care Centre provision, which has expanded its acceptance criteria, it now takes ambulances directly, and it takes walk-ins as well as referrals across from ED. I think we are reasonably well prepared. We are lucky in this part of the world that we have that support from mental health. That's not to say that there isn't more to do for individual patients.
Very good to see some of the data that you're referring to.
Yeah.
So I'll try and pick up the flu and the COVID point because I think they're both important for the forthcoming winter. Flu, the key is peer vaccination. So it's about getting people who you trust, who you know, going out and offering vaccination, and that's very much our plan for this winter. The national data says very clearly that you can up vaccination rates if you make it easy for people to get it. And that's where our work must be. In terms of COVID, that's going to have to be a dynamic situation as we go through the winter. So we have a group that meets in the trust on a regular basis to look at infection control and to look at viral infection rates. There has been a joint decision by the Joint Committee on Vaccination Immunisation, which sits as part of NHSE, with NHSE, to not offer a COVID vaccine to health staff this year. I think we need to watch that very carefully. One of the issues for me is that UKHSA are not monitoring COVID in the same way that they have done previously. And I think we run the risk of missing spikes that may come along. We are doing some enhanced monitoring ourselves as an organisation. We've looked very carefully at what we offer over the winter period. So one example would be our elective surgical patients. We've made a decision that we're going to offer lateral flow tests on the day of operation to all patients coming through. And the reason for that is that we know if we anaesthetise a patient who has COVID, their outcome will be very significantly worse than if we defer their operation. So we may see a slight decrease or an increase in on-the-day cancellations, but I think that's the right thing to do from a safety perspective. We're also going to be monitoring all of the viral causes of respiratory infection in patients being admitted with respiratory illness. We will also monitor it for patients going to certain parts of the hospital where they don't have an obvious respiratory illness, but they would be at risk of infecting other immunocompromised patients. So that's our stroke unit, our renal unit, our oncology ward, all of those places will have enhanced monitoring in place during the winter. So that's a sort of brief version of what we're doing as an organisation. But I think there is a tension between what's happening, what we're choosing to do locally, and what the national policy is around this year.
But it's good to have those controls.
So now I'm going to be vaccinated, so we're going to come around and vaccinate the board. Okay, well then, absolutely, we'll do that. Just on the winter plan, I think there's a lot of work being done to get us to where we are, and I think you'll see really hard what's been done by your team to get us through to this stage, in terms of where we are. But I would just caution that there's a bit of work to be done around surge and surge planning, because we are landlocked in terms of bed capacity, so the utilisation of SDEG, CDU, and particularly for our frailty patients is going to be really pivotal as we get well through winter. And then a final wee point, I think it's just worth noting, all the mood music and nursing is this year more than any year we need our partners much more to help increase capacity for performance, and we still have work to do in our 12-hour waits in ED. They are too long and there's too many, so understanding what's driving that and having a real lens on every single patient, which is clearly what Adam expects us to do, is the final point.
So it's Kevin and then Adam.
Yeah, I'd like to pick up, I do this every year, about the flu vaccinations for our staff. My overarching concern about support staff who have potential to impact people with high respiratory issues or immunosuppressed patients, and how we deal with that. I know there have been lots of discussions, but I send my porters, some of which make a clear decision they don't want to have a flu vaccination, to respiratory wards, and there's a much higher potential than it's that obligation. I wonder where I balance that with regards to my obligation to ensure safety of the patients against the ability where I send my staff and where I decide not to send my staff.
Adam?
Yeah, just want to pick up a kind of pulling together point really around the money, and it reflects both in terms of the IPR, that when we try to do that synergy, because of the requirements to make the savings, we're reducing admin headcounts, because not necessarily the pace of redesign manages to run in advance of the headcount coming down. Things like complaint responses that we rely on admin people to move things around have been shifting out, and we are seeing areas where there was a quality impact. We have to be very mindful in this winter plan that whereas we might want other partners to be able to increase the number of mental health beds being bought or put extra community services on, etc., all of these individuals have planned for their year, and there is a clear message. There is no winter funding pot that's going to suddenly be thrown out, which in the past the NHS has often relied on. So some of the opportunities that we might naturally go to may not exist because our partners' boards will be sitting there saying we've got to hit our financial plan as well. So I think we shouldn't assume that there's a cavalry waiting to come over with money in the backpack.
So the final question we haven't addressed yet is, would we like this to come back to FPPC at the end of September, this document?
I think that's a good idea.
Okay, so that's agreed to come back to FPPC. I can see there's an awful lot of interest in the paper where I did as well. Okay, unless there is...
Just for clarity then, you want FPPC to give to make the decision about the assurance checklist on behalf of the board? Yes. Okay.
Absolutely. And everybody's comfortable with that? Yeah. Okay. Is there any other questions on that? Stuart?
Sorry, not on that, other business.
Any other business?
So I just realised that we didn't actually think formally improve the resin days, which the board needs to do.
Is everybody happy? Thank you, Stuart. Is everybody happy to approve the reserves? Yeah. Okay. And Teresa?
Yeah, I just wanted to say congratulate our Chief Executive for receiving an honorary doctorate of quality improvement science on behalf of our local university. I think it's a great honour, not just for Adam, but for all of our organisation, everybody who works in it, because it's about the improvement, it's the science, it's the technology, it's our teams, and most importantly, it's about our patients. So I just want to acknowledge that and say, on behalf of all of the execs, we are very proud of it.
Thank you very much.
Really well done on behalf of all the heads.
Yes,
Well done.
yes, but where's the costume?
It was a one day.
Okay. Are there any other items of any other business? So apologies for overrunning, but the next meeting is scheduled for Wednesday the 19th of November and it'll be online. Okay. Thank you all very much.